The first annual Riordan IVC and Cancer Symposium presents IVC Infusion Protocols and Pharmacokinetics. Your presenter, Jorge Miranda.
Dr. Jorge Miranda Massari is professor at the School of Pharmacy in the Medical Sciences campus of the University of Puerto Rico and is a registered pharmacist. He's a consultant with the prestigious Center for the Improvement of Human Functioning, and he is the creator of the first course in integrative medicine at a doctoral level and the advanced practicum in integrative medicine at the School of Pharmacy. He also received the prestigious Puerto Rico College of Pharmacists, the Innovative Pharmacist of the Year in 2008. Please welcome Dr. Jorge Miranda to present IVC infusion protocols and pharmacokinetics.
Thank you, Steve. Thank you. Well, today we're going to be talking a bit about pharmacokinetics and the protocol. So we better start off with what is pharmacokinetics. But before talking about pharmacokinetics, we need to define what is pharmacodynamics, which is the effect of the drug on the body, or what the substance does to the body, as opposed to pharmacokinetics being what the body does to the drug or to the substance. And the way we describe it is by mathematical models that describe how a substance is absorbed, distributed, metabolized, and eliminated from the body. Now, when you look at the USDA Agricultural Research Service, they have these plasma concentrations of ascorbate that will define what is adequate, what is low, and what is deficient, in general terms for general health. Now, this information is important because if you're deficient, you will develop scurvy pretty quickly. Now, there's a paper published in 2005 which talk about vitamin C deficiency in cancer patients. And what we learned in that study published recently was in 50 patients with advanced cancer, average age around 60, 65, that 30% were deficient in those terms that I just defined, and 42% were low. If you sum that, it would mean that 72% really had low levels. So with that alone, the medical establishment should have a clue into the importance of vitamin C in cancer. And the other thing is that low plasma was associated with low albumin, low platelet, high CRP, which is C-reactive protein, and all of you know is an indication of inflammation, and a shorter survival. So I guess the point of this outcome is that vitamin C is important. The level of vitamin C is important in the outcome of cancer, even if we don't look to IVC. So we'll be talking a bit about how vitamin C is absorbed, how there's some issue of absorption and saturation in this process of absorption, movement through the body, and elimination in the kidney. First thing, in terms of absorption, there's an issue of saturation. It's dependent on a diffusion and active transport. And I think this is important is because it was mentioned before that the Mayo Clinic tried to reproduce what happened with Cameron and Pauling, and weren't able to reproduce the same results. On the Cameron and Pauling, we have increased survival, and in the Mayo Clinic studies, didn't happen. Now, the difference was that the way it was given. So you couldn't really decide, looking into the two studies, what happened. So Mark Levine looked into the absorption of vitamin C in the 90s and he documented how this was important. So we know there's an active transport system that is sodium dependent and that is saturable. So if you give large doses of vitamin C, you saturate and you're going to be very inefficient absorbing. So how you can use this in your favor? Well, what you do is that you give enough, but not enough to saturate, or just to barely saturate and then wait till the body has handled that, and you can give it again so that you can absorb more efficiently. And it has been looked into the absorption in terms of the amount you can give, and oral ascorbic acid will turn into dihydroabsorbic. When you eat something that has vitamin C, it's very nicely absorbed, 80 to 95. But when you go up in the doses, the bigger the dose, the smaller the percent is absorbed. So you don't want to give very large doses at once, but divided, so that you don't have this problem. There are some preparations that engulf the vitamin in a liposomes made up of phosphates and fatty acids, so that the body doesn't recognize that is different molecule. It's a fatty molecule going inside, so it improves absorption. Cathcart developed the method of utilizing vitamin C that we know about, called bowel tolerance, and we know we're getting there because of the diarrhea it produced. So we have to cut back, and obviously, it is not something that everybody wants to do because it's uncomfortable. But at the point, it achieved the maximum possible absorption into the body using the oral route. Hickey, Dr. Steve Hickey from England, brought a different concept which is called dynamic flow, and it's based on the fact that the membrane pumps the vitamin C out of the body or inside the body, depending on the amount there is using an homeostatics. So what we want is to go into a level that you can absorb the maximum and not excrete the maximum dose, thus using the capacity of the body to achieve a point where the reabsorption mechanism are still functioning, so you don't get to excrete through the renal tubules as much. So, and one of the point is that this is something that changes. You know that one thing is the saturation of the absorption, one thing is the reabsorption from the renal tubules, and these two mechanisms are not fixed. They change when you have disease states. So it means that you can absorb a higher amount of vitamin C when you have a disease state that uses that vitamin C. And the kidney reabsorbs ascorbic acid, but not the hydroascorbic acid. So when we talk about the levels of vitamin C in the body, you have to refer to the dose that the person is taking. So we put there like 3 levels, which we call the nutritional physiological level. And those are the ones you achieve when you give between 30 and 100 milligrams. And there you have a couple of references. The other level would be the low intermediate concentrations you get with a supplementation level, which could go from 0.15 to 0.2 millimoles. And then the intravenous concentrations that you achieve when you give intravenous doses that can go from 10 to 100 milligrams or so. So, excuse me?
100 grams.
Grams, I'm sorry, yeah. 10 to 100 grams. The dynamic flow models will describe the dual phase pharmacokinetics, where low gram levels of ascorbic acid will achieve less than 70 micromoles per liter, and where the half-life of vitamin C is longer, 8 to 40 days. But when you give higher doses, the half-life goes down because the excretion in the tubules changes. You don't longer reabsorb as much in the renal tubules. So in the Journal of National Cancer Institute 1998, they wrote about the biologic action in relation to cancer of vitamin C. And they basically put out that the tumor cell apoptosis was 57.6 and the necrosis was 33.1 at levels of 33.7 millimoles. And that goes in relation to the secretion of collagenase by cancer. So this is one of the mechanism of actions of vitamin C. So as Neil told before, and Michael also talked, we have many different mechanisms of actions, and depending on which mechanism of action vitamin C we're looking at, the concentration will be different. So in order to improve in the dose of vitamin C in the treatment of cancer, we need to realize that we would like to cover many of these mechanisms, and we not necessarily need to go to the very highest concentration, because in a particular cancer we might not need to cover like the highest concentration, that are the ones that have the killing effect, and you must in some cases need that cleaning effect, but you don't need to go too higher before you in order to avoid some of the problems, and we'll be talking about that soon. So frequent doses allow for sustained high plasma because half-life goes down, and in order to avoid going too low, you would like to have repeated doses. So here we go, sodium-independent transport shuttle moving the vitamin C into the body and recovering the vitamin C that is going out in the renal tubules. So when we're talking about distribution, 200 milligrams should achieve somewhere in the concentration between 0.07 to 0.85, and doses that were beyond 200 milligrams go beyond the linear portion of the curve. And absorption is complete before that, but when you achieve higher dosing, well, you know that part of the dose is not going to be absorbed depending on the situation of the patient. Remember, these studies by the group in the NIH were looking into healthy volunteers, which means that people with disease states will be able to absorb more. Now, people at 3,000 milligrams every 4 hours had concentrations that were nearly 3 times the amount that you have with 200 milligrams. So you know you can increase absorption by dividing the dose and giving them frequently. Now, when you give IV, you go to another level. 50 grams, for example, can achieve 13 millimolar. Now, ascorbic acid and dehydroascorbate in plasma can be transported either freely or bound to albumin. And it penetrates into the cells and into the tissue and crosses the membranes because of the resemblance that they have to glucose. They go into this mechanism that uses glucose to go inside the cell, the GLUT transporter. Michael didn't mention something about a story, very interesting story, related to the GLUT transporter. Remember Niels mentioned about Dr. Goldie being scared about using vitamin C because they were antioxidants and it could negate the value of the chemotherapy being pro-oxidant. Well, at a conference in the NIH discussing that particular issue, we had the opportunity to talk to Dr. Goldie, and basically we were in a taxi together. Yeah, it was the most amazing thing because at the point, the NIH sometimes organizes these events, and most of the time they pay to other companies to organize some logistics, and sometimes it doesn't happen right. So a lot of people were trying to get out of the talks into the hotel for a poster presentation, and we need to go and take a shower and get there early. So when we were doing that, there weren't any buses. We had to call for taxis, and there weren't taxis coming, but Dr. Goldie was there and had a taxi. So we talked to him and he agreed to have us on the taxi. When the taxi came, all people were coming out. Everybody wanted to go with Dr. Goldie in the taxi, but at least we were there. And Dr. Bruce Ames, which was the keynote speaker at the conference, could fit in, so he came in the front. So what happened was that we put Goldie in the middle, Michael on one side, me at the other side. So when the taxi started going on, we said, Dr. Goldie, by the way, in 1999, you have this research paper in the journal Cancer Research, in which you brilliantly define that the way that vitamin C can go inside the cell was using the GLUT mechanism. And that is outstanding. However, your group mentioned that is of concern, the use of vitamin C, because vitamin C is an antioxidant. And when you use them along with chemo, it will negate the effect. And I say, yes, I know that we'd say that. Well, the way we use vitamin C in cancer therapy is not as an antioxidant. We use it as a pro-oxidant. And it was kind of interesting looking at this authority, like the research director of Sloan Kettering's, putting his hand like this and say, gee, I didn't know that. So that was interesting. And the most interesting part was having Bruce Ames turn to us and say, oh, you know what these boys are saying? He's a very mature person. These boys are saying it's true, because I was talking to Mark Levine, the NIH expert on vitamin C, and he was just telling me about this. So we had this interesting experience. Now, what else? Vitamin C accumulates in the tissues. And in some tissues, the concentration is much higher than in plasma. And this is important because there are things we know that will happen that are different in the healthy environment, in a relatively healthy person, as to opposed to a person with infection, or in our concern with cancer. But you see, we're almost there in terms of getting approval, complete approval we have IRB approval, but we still need the CRC approval to begin a pharmacokinetic study in normal volunteers. And as all of you know, we need to know what happens in normal person because in the sick person will be different, and we need to define how much different. Well, believe it or not, there's certain authorities in the area that has questioned why we're doing this. But I'm glad to say that in this conference, I've talked to several people that really understand the importance. So we're moving forward, and hopefully we'll begin at the end of this year, and at some point next year, we should be having the paper out. So there are certain tissues that concentrate vitamin C, and I'd point out that leukocytes are one of those, because in some of the saturation studies that dealt with the issue of what dose is the appropriate dose for normal dietary intake, the leukocytes were used and they saturate quite quickly. So it's a problem, because if you use that, you will leave the consideration of other tissues that are not saturated very quickly, and therefore your interpretation of how much you need will not be accurate. But we know that, and it's not going to be very likely that the government will raise the dietary intake recommendation. Now, there's certain things that we look into. What's the uptake of ascorbic acid in cancer cell? We know the metabolism is anaerobic, so that means the mitochondria will not be making ATP, and almost all the ATP has to come from what? The glycolysis. And therefore, that's the reason they need a lot of GLUT2 transporter to be in the membrane, and that's the reason when you compare the absorption of ascorbate from a malignant cell to a normal cell, the absorption is going to be much higher. And the most beautiful thing is that it's not there, but the low catalyze level on those cells will allow for a lot of peroxide formation, and that's how it's proposed of the killing effect. Now, since we have a lot of catalyze in the other cells, it doesn't, it's not toxic to the normal cell. So it's a combination. So we have different doses that we can refer to. The nutritional doses, acute deficiency, subclinical deficiency, base level, dynamic flow, and then the pharmacological doses, oral treatment going to large amount till bowel tolerance, and then intravenous, which is the most effective for cancer treatment. And then we mentioned the paper by Casciari, in which we know lipoic can help the killing effect. How can it do it? Well, we still don't know, but we believe it might be a multi-mechanistic way. One of those improving the entrance of vitamin C into the cell. Because if most of you know, lipoic acid improves, like it has an insulin-like effect. So there's a chance that it could be like insulin trying to improve the entrance of vitamin C into the body. It may facilitate the flux of the hydroascorbate, and the recycle of vitamin C should have some important effect too. So you all know this. We've been saying a couple of times that there's a synergistic effect of lipoic and ascorbate. And in terms of metabolism, we need to learn a whole lot more, but we know that the metabolism include the hydroascorbic, oxalic acid, methyl ascorbate, and some others. Now, I guess one of the key things I want to say is that even though oxalic acid has been emphasized so much because of its possible relation to renal stone formation, there's a really recent a paper by the group of Hofer in which they gave pretty large doses. I think I have it later on this presentation. Pretty high doses of intravenous vitamin C, and the amount they recuperate in the urine was quite low. And the bottom line is that you need oxalate present all the time to produce a stone. So in order to really be able to produce a stone, you have to keep giving large doses for months and months and months. And unless you have a particular biochemical risk, like it was say before, people who are stone formers, these are the people that are the big concern. Excretion, well, as I say, half-life of 30 minutes when the concentration is not very is high, but because it's much larger when the concentration is not very high. And okay, we have only 5 minutes. This is a table in which we look at the pharmacokinetics of the vitamin C IV, looking to half-life between 1 and 3 hours. And now we can move on into the intravenous protocol. I won't repeat much of the Pauline Cameron, but you know they give a little bit of IV and then continue the oral doses, and they have good results in terms of greater survival. 22% have over 1 year survival compared to 0.5 of the control. Murata protocol had 2 sites, and they increased the survival and improved the quality of life, given mostly oral doses. The Riordan protocol we published in 2003 said to start with 15 grams and do G6PD to avoid possible problems. And you could go up to 100 grams. There was this report of 7 cancer patients. The safety was important. The outcomes were good, also surpassed life expectancy. It was non-toxic. And then the phase 1, which Michael mentioned, basically it was well tolerated, one stable disease. And the thing is that plasma ascorbate between people who had stable disease or not was bigger. So the concentration the bigger seemed to have a better outcome. The Korean people, very short study, very modest doses, and yet on the global health scale, it improved lifestyle, it improved physical, emotional, and cognitive outcomes, and symptom scale were better. The the Cancer Treatment Center of America also have this FDA approved phase 1 study, and they had dose escalation. The results have not been published. Now we know that there are adverse effects on mouth dryness, edema, nausea. That with good hydration are well treated. The renal, so I'm not going to mention that again. I just mentioned everything. So bottom line, there's a bunch of mechanisms that act. So we need to know what's the most effective dosing regimen. Well, diverse mechanism of action, higher concentrations, millimolar, have a substantial important effect into the formation of peroxide, and they seem to act on the more rapidly dividing cell. Now, this part here of wash out to avoid too much ascorbate is because we were like saying, okay, we want a good amount of vitamin C in the body, but we don't want to saturate the whole system, because then what you have is that is metabolic complication. So we came up with these different levels of saturation: GI saturation, which is the mechanism of absorption; renal reabsorption saturation, which will affect the way the vitamin C goes out faster. The tissue saturation, we're talking more into interstitial and cellular, not just leukocytes. And then the systemic, which is the one we don't want to achieve, which would be when the concentration of the plasma and tissue is high enough to start disturbing the biochemical parameters. And in other words, this is where you have the negative impact of vitamin C. So where do you achieve this? We don't know yet, and this will probably change between individuals, but obviously we want to achieve millimolar concentration to achieve killing effect, but not very high millimolar effects to avoid those systemic saturation effects that we're talking about. So we want to develop then a schedule dependence, and the dose we still don't know, and that's why we want to keep on having this type of symposium, these panels to discuss which are the optimal concentration we want to achieve. The doses should be anywhere between 50 and 100 grams probably. We want to achieve the peroxide effect, which is like the most potent effect, and well, and the one that needs the most dose. How much? 2-3 times a week. We want to avoid systemic saturation and produce cyclic peaks to match the renewing of layers of malignant cells, so that we keep killing all the time. Duration, 12 months, years, we don't know. And it will depend on the quality, on the objective, quality of life, survival, tumor marker response, tumor growth response, metastatic inhibition. And there's other issues we want to address at some point, which are to add things that are important to improve the therapy, the outcomes, reduce adverse effects. How about calcium? Because we know calcium goes down. Potassium, because it could be a problem, going down too. And magnesium to avoid other complications. There are other things that we may have to add, and we'll talk about that at some point. So we need to do some studies, and we're planning on that. And with that, we'll address questions. No questions? Here. What's the question again?
When you achieve systemic saturation, what would you be looking for? How do you know? How would you know in a patient?
The patient will feel bad.
Oh, okay.
So, you know when you're giving high doses, people start complaining about thirstiness. If you continue giving higher doses, it will be more uncomfortable. So you don't want to achieve that. People with receiving IVC should feel good, in general. Yes?
Since your peroxide effect is from hydrogen peroxide, what's your feeling about using hydrogen peroxide intravenously in conjunction with vitamin C or instead of vitamin C, or how do you feel about that?
Well, you see, vitamin C will give you benefits, and we'll talk about this morning, even without that effect. However, even though I haven't looked into the literature of using peroxide alone, there are claims that it could be beneficial. So that's something we have to look into. I'm no expert on that. Yes?
Could you use a microphone, please? Okay. There's one here.
The mechanism, concerning the mechanism of killing the cancer cells with peroxide, my understanding from the Levine papers are that the concentration of peroxide is extracellular. The concentration of the catalase difference between the normal and the cancer cells is intracellular. Does that still explain the difference, the fact that the catalase is high in the normal cells and not in the cancer cells, even though the peroxide, because I think when Hugh Riordan proposed it originally, he thought that it was changes intracellularly in the peroxide.
We still think there's an intracellular peroxide formation, and in fact, some people are looking into that. We haven't looked ourselves. It's not easy to do that. But in fact, there are some groups that are looking into intracellular.
if that wasn't the case, would that explanation still hold, the difference in the intracellular differences in catalase between cancer cells and normal cells, would that explanation hold up as explaining the difference even though the peroxide is extracellular?
Well, it's a good point of reflection, because it's more difficult. If we couldn't find intracellular peroxide, it's more difficult to explain because the reaction would have to be in the outside membrane, and you would think, well, how could this happen? It would be more complicated.
The first annual Riordan IVC and Cancer Symposium was brought to you by the Center for the Improvement of Human Functioning International, located at 3100 North Hillside, Wichita, Kansas, USA. To learn more about the center and what we have to offer, please visit us on the web at www.brightspot.org.